to see from the resident and learner's perspective as well, because it helps us reflect on how we can learn better and perhaps become teachers ourselves as we evolve into that role. So speaking of which, I will share my screen and talk about neurosurgical spine treatments of intractable pain. So this is meant to be a review of some topics, and for some perhaps less discussed or less utilized treatment options, perhaps an introduction to some regarding treatments of intractable pain that as neurosurgeons we can apply, specifically focusing on spinal treatments and spinal options. So with that, I just want to, I guess, begin the discussion about how we can classify pain. And maybe I can ask Ansley to name some types of pain. I know this is an open-ended question and it can have many answers, but what are some ways that we can classify pain?
I think we classify pain oftentimes as neurogenic or non-neurogenic broadly. So nerve pain versus like body pain. There's pain with a discrete source that can be targeted with specific things versus like diffuse idiopathic pain that you might manage a bit differently. There's also like different sensitizations to pain. So if somebody's like a chronic pain person, it's going to be treated very differently than if it's acute new pain.
That's a great answer. There are many things you could have said here, but that leads perfectly into the next slide, which is neuropathic versus nociceptive pain. And as you mentioned, neuropathic pain is caused by an insult to the nervous system itself, right? So it could be the peripheral nerves, it could be the spine, it could be tracts projecting into the brain, but neuropathic pain involves the nervous system. It may be described as constant, lancinating, intermittent, shooting, burning, tingling. It may have varying qualities. It's often associated with allodynia, where just a simple touch is perceived as a very unpleasant feeling, sometimes resembling electric shocks. Might sound similar to the trigeminal neuralgia pain in that sense. That's as opposed to nociceptive pain, which results from actual tissue damage, and it's also known as somatic pain. It's an actual stimulus that is then sensed by the nervous system and transmitted for you to feel that perception of pain on your body. And it's generally well localized, described as aching or sharp. However, when the nociceptive pain is visceral, it tends to be less well localized. It can have a cramping quality if it's affecting your internal organs. It may result from trauma, caused tissue damage, infection, chemical irritation. Another way that we can classify pain is acute versus chronic, as you all well know. And acute pain tends to have a very well-defined temporal pattern. It's associated with both subjective and objective signs. So when people feel acute pain, there's hyperactivity of the autonomic nervous system. We, as surgeons, have a lot of experience, even in the OR, seeing changes in vital signs. And so it's something you can see a response to autonomically. As opposed to chronic pain is often thought to be pain that has persisted for at least 6 months, and it causes an adaptation of the autonomic nervous system. And oftentimes you lack those objective signs common to acute pain, and that makes it really difficult to judge and treat when there are other confounders. However, over time, it leads to marked changes in personality, lifestyle, and functional ability. and it requires treatment of the cause of the pain, but also of its sequelae and its consequences, or psychological and social consequences. So pain is treated by all medical specialists, and often a number of different methods can be attempted to treat pain. When pain is not adequately treated medically, through therapy, through other means, we have a very important tool set within our neurosurgical armamentarium that is important to be aware of and versed in, so that we can apply it and potentially, really help a lot of patients. And so therefore, let's talk about some of the neurosurgical approaches, starting with some of the more common ones that we might more typically see. But in general, they can be divided in two categories, and those are ablative approaches and neuromodulatory approaches. Again, as I mentioned before, these can be applied to the peripheral nerves, the spine, and the brain. However, I'm going to focus on those involving the spine. Furthermore, the neuromodulatory can be electrical or chemical in nature. So to begin with, I'll just start with intrathecal pain pumps. Is Dan with us, perhaps? Or if he's away, maybe Chi can tell us how the intrathecal pain pumps perhaps work, as opposed to systemic opiates or medications.
Yeah, so we implant a program pump that will deliver medications to the cerebrospinal fluid. A lot of times is opioids, but then it can also be like anesthetics.
Right. That's true in terms of logistically what happens. Now, as opposed to just giving the medication systemically, introducing it directly into the intrathecal space simply delivers it directly to increase the relative strength of the drug compared to its oral or intravenous equivalent. Therefore, we're giving it directly to the nerves, to the spinal cord, and not, I guess, diluting it systemically or having to force it to go through other metabolic pathways. Initially, the intrathecal pain pumps focused on failed back syndrome, but the indications have expanded to include complex regional pain syndrome, postherpetic neuralgia, painful peripheral neuropathy, cancer pain, and in fact, now cost analysis indicates that intrathecal delivery is the most cost-effective mode of opioid delivery for patients requiring long-term management for cancer. For cancer being at least 3 to 6 months, and for non-malignant pain, 11 to 22 months. And for patients who may have a shorter life expectancy, one can perhaps consider external sources, meaning that if really necessary, you can still deliver it into the intrathecal space, but perhaps not through an implanted pump itself. As far as the medications that can be given into the intrathecal space, morphine, baclofen, and saconitide are currently the only agents approved by the US FDA for use in intrathecal pumps, but other narcotic and non-narcotic agents are routinely used. You can use them individually or in combination. And other agents include hydromorphone, fentanyl, as well as clonidine, bupivacaine, calcium channel blockers. And the use of all these medications has expanded also the indications and possible ways that we can use intrathecal pumps. Typically, the patients who are candidates for the intrathecal pump will undergo a trial. And this trial involves either injecting the medication directly into the thecal sac through a lumbar puncture and seeing its effect through the one-time injection, or having a catheter that will temporarily deliver the drug from an external source. Based on the response from that, then what the next step will be to judge whether to place the implantable pump. And many of you guys have seen these systems, very much like a lumboperitoneal shunt kit, except that it will have the connections to the pump itself, and the pump itself is placed subcutaneously either in the abdominal wall or in the gluteal region, in a well-padded pocket, connecting directly to the catheter, leading subcutaneously to the posterior lumbar region and traveling intrathecally. Intrathecal pain pumps, we often talk about baclofen pump withdrawal, but besides the withdrawal effects, giving the medications and having the intrathecal pump can have a number of adverse effects that we may not think about as much in the inpatient setting, but as these patients can have constipation along with urinary retention, and urinary retention can typically be relieved by decreasing the dosing. They can also have a lot of itching that usually abates over time. Myoclonus can also happen, usually develops over months, and may require titrating the dose down in order to abate it. And if the pain is diffuse, especially in patients with cancer or involves the upper body, then one can consider delivering the drug intraventricularly to the brain, which would be a separate topic. Another treatment that we tend to see fairly commonly is spinal cord stimulators. And spinal cord stimulators similarly has expanded significantly in its indications and its uses, from failed back syndrome as to ischemic pain of peripheral vascular disease, angina and anginal pain, to neuropathy, to peripheral nerve avulsions, to complex regional pain syndromes, phantom limb, cancer pain. As far as the position for the spinal cord stimulator, normally there's three main areas that we tend to think about. So for arm and neck pain, the lead will typically be placed in the upper cervical spine, so either retrograde from occiput to C3, or in what's called a blooming flower configuration, up to C1-2. In terms of back and leg coverage, the lead is typically placed over the T9 to 10 region, and specifically for recurrent anginal pain, it's placed typically over the T4 to 6 region. And there are other regions and other uses that are evolving, but this is kind of a broad overview of the more common ones. Now, there are paddle and percutaneous electrodes, and the paddle leads require a wider exposure and laminotomy in order to place them, but various studies have suggested that it may lead to higher pain relief. As described, typically these are placed, if it's a paddle lead, it'll be through a small open incision, through a laminotomy defect and pushed epidurally in the dorsal epidural space along the midline up 1 or 2 levels beyond that laminotomy defect, tunneled in the subcutaneous tissue and connected to a stimulator, a battery pack that is normally placed around the buttock. Now, as far as the way that a spinal cord stimulator works, there have been numerous theories and proposed mechanisms, beginning with that proposed by Wall and Melzack in 1965, the gate control theory that postulates that the activation of cutaneous touch signals transmitted via larger myelinated A beta fibers subdues afferent pain signals transmitted by smaller C fibers by gating output from the dorsal horn shared by these inputs. So by stimulating the input from the larger myelinated A beta fibers, you're in a way overcoming the painful stimulus from the smaller C fibers. However, a number of other possible mechanisms have been not just theorized, but suggested through various animal studies, such as the paresthesia-free waveform, where Jensen and Brownthorne suggested that spinal cord stimulators provide analgesia by stimulating the dendrites of GABAergic dorsal horn islet cells, which are oriented in the same rostral caudal direction as the spinal cord stimulator electrodes. Additionally, it's also been theorized that it works by modulating neurotransmitters through glial cells, and that decreasing glial cell activity and stimulation of the dorsal horn increases acetylcholine and GABA and decreases excitatory amino acids. Spinal cord stimulators have also been found to decrease sensory evoked potentials, and therefore it may modulate cortical activity, but there's a question on whether that itself correlates with the pain relief. And then lastly, they can activate endogenous opioids in rats. Given mu or delta opioid antagonists, they experience a decrease in spinal cord stimulator analgesia effectiveness. Usually with the stimulators, various parameters will be adjusted to provide the most benefit to the patient, such as amplitude pulls width frequency, as well as the programs of the stimulation being tonic, burst, high frequency, low frequency. In terms of spinal cord stimulator complications, over time, there can be lead migration. In fact, over its lifetime use, this can happen in up to 15% of cases, which can be at twice as high in the cervical, interestingly, just due to the motion of the cervical spine. Infection rate tends to be similar to other procedures involving implants, 2.5 to 3%. And loss of therapeutic effect occurs in 13, almost 15% of patients. About 8% of these lead to explant due to various reasons. Now, although we're most of us are likely familiar with the spinal cord stimulators and the implantable intrathecal pumps. The cordotomy and myelotomy are perhaps less often seen. So I want to touch on those as well. The cordotomy and myelotomy briefly can be thought of as cordotomy, an interruption of the spinothalamic tract, and pain signals from the spinothalamic tract, and the myelotomy is an interruption of the dorsal column's visceral pain pathway. And as opposed to intrathecal drug delivery, these methods induce immediate onset of relief. There's no maintenance of the therapy, refilling the pain pump, or changing the stimulator battery. And they're very cost effective in this way and being a one-time intervention. Cordotomy specifically is highly effective for the treatment of nociceptive pain and nociceptive pain due to cancer. And as we discussed, nociceptive pain is direct tissue injury or involvement from a tumor. Now, owing to the decussation of the spinothalamic fibers, the cordotomy is effective for pain that arises 2 to 5 segments below the targeted spine level. So if you have pain, intractable pain arising from a C5 or C6 dermatome, you would normally target about a C1 to 2 level for your cordotomy. And cordotomy is safest when performed unilaterally, because it's typically performed high up in the cervical spine, and this helps avoid Ondine's curse by the bilateral interruption of reticular spinal fibers. Maybe Matt can tell us what Ondine's curse is.
Yeah, Ondine's curse is the hypoventilation syndrome where you have to like consciously breathe. So when you sleep, you stop breathing, I believe.
Yeah, correct. People who have an issue with the reticular spinal fibers, medullary problems, they can have this central hypoventilating syndrome where when they do fall asleep, they can have apnea in more severe cases, even while they're awake. Therefore, cordotomy high up in the cervical spine is typically performed unilaterally to avoid this. I know this slide has a lot of words, but I want to just summarize how, the technique behind the percutaneous cordotomy. The way I've seen it described is that typically a myelogram is performed, and a baseline CT will be taken of the region, and the patient will be placed in Trendelenburg, or the contrast allowed to rise up high enough into the cervical spine. And then the skin to dura distance is measured and noted on a 20-gauge spinal needle, through which one can also pass a disposable percutaneous electrode. And this 20-gauge needle is advanced towards the C1-2 interspace under CT guidance, taking short scans as one advances the needle, using local anesthetic and sedation as needed. Now, it's important to note that for lower extremity pain, the target of the spinal needle is just anterior to the anterior posterior midpoint of the spinal cord. But for pain higher up in the chest or upper extremities, a more anterior target, about 1 to 2 millimeters, is chosen. Following that, the tip of the needle is advanced until it's adjacent to the thecal sac, and the stylet is replaced with the electrode itself. And with the electrode, one begins to measure impedances. Using the impedances along with tactile feel, you can determine the location of your electrode. So when you've passed intradurally into the CSF, the impedance will measure less than 300 ohms. As you near the P and abut the P of the spinal cord, the impedance will significantly increase to the range of 300 to 500 ohms. And then entrance into the spinal cord, normally there is tactile feedback to that, and the impedance will also increase significantly to greater than 700 ohms. At this point, another image is obtained. The location is checked again. Because of the pressure it takes to actually penetrate the PIA, it's not uncommon to go a bit beyond the target. And so one has to keep that in mind. The electrode is withdrawn until it sits radiographically where you want to ablate. And then intraoperative neuromonitoring is done for both sensory and motor effects. And you can use intraoperative monitoring or simply light and sedation and re-examine the patient and then begin doing the ablative procedure, increasing the temperature from 60 Celsius to up to 80 Celsius for 60 seconds to perform the ablation through the electrode. And the goal is for that at the end of the ablation, you have moderate numbness in the area and a decrease in the pain in the area where the patient feels pain and that you're targeting. So as opposed to the percutaneous cordotomy, the myelotomy is normally employed for patients with intractable pain associated with malignancy in the abdominal or pelvic region, with the goal being interruption of the ascending pain pathway. As mentioned before, within the dorsal columns, a spinal level with myelotomy is chosen rostral to the source of pain. So if one is aiming to treat upper abdominal pain, the T3 or T4 level is typically chosen. And for perineal pain, a T6 to T8 level is often chosen. Various techniques can be used for the myelotomy, including as a percutaneous radiofrequency myelotomy, very similar to the cordotomy, versus an open punctate myelotomy. When one performs an open myelotomy, a single level laminectomy is performed. Because it's performed in the thoracic spine, which has additional rigidity from the rib cage, one can perform a wide laminectomy and find the root entry zones. And by finding the root entry zones on each side, that can help in identifying midline. That way, a midline dural opening is performed, and the midline PIA is coagulated with bipolar, being careful to preserve the midline dorsal vein if seen, and a 16 gauge angiocath is used to create the lesion. The catheter portion of the angiocath is cut, and 5 millimeters of the tip is exposed in order to obtain that desired 5 millimeter depth of the lesion. And typically 4 lesions are made in one location, just simply by rotating the angiocath 90 degrees between lesions, with the goal of creating lesions that extends 0.5 millimeters from the midline bilaterally, a depth of 5 millimeters. The percutaneous myelotomy is technically similar to the percutaneous cordotomy in terms of advancing the needle. However, it's performed at the dorsal midline. Usually it can either be performed at the occiput C1 level or in the thoracic spine, in a similar technical fashion to that described for the cordotomy. In visceral pain, one can either interrupt the commissural fibers associated with the anterolateral system, the midline fibers of the visceral system, or aim for both. So that, to me, was a good review for me, and I hope for others, of the different things that we can employ, because occasionally we do get consults where pain management is not able to adequately control pain, and it's important that we counsel them on these other options that we do have. So that's all I have, and I'll open it up to those who have comments or have additional teaching points.
Thank you, Alejandro. I'd like to make an opening comment, but we have some experts like Dr. Capel, Dr. Weiss, and Dr. Margettis who probably should comment further. Very important topic, excellent topic. Can come up on the boards, came up on my board, a pump question. We all need to understand it crosses the fields of spine, functional, and general neurosurgery. And I want to give you a special commendation, Alejandro, for not only the great talk, but this came up on a question in our spine conference only 24 hours ago. And I believe you probably put this together in the last 24 hours. So thank you for doing that and really taking the question and really running with it. My final point is I think that these technologies are somewhat still underutilized within our field. And the pumps for pain in particular are probably underutilized because it's hard to find people who manage them. We don't mind putting in the pumps, but for rehab and for baclofen, for spasticity, we have people who manage it in rehab. For pain, we don't have it as much. But anyways, these are important things, and some of the esoteric ones are more historical and not done so often, but pumps and stimulators are very common. So let's see if Dr. Capel, Weiss, or Margettis want to comment on it.
Happy to take that. Thanks, Tanvir. Yeah, first of all, Alejandro, really very comprehensive, very nice talk. A couple of comments. I'll echo Tanvir's thoughts about intrathecal drug delivery. In our field, the use of intrathecal drug delivery vis-a-vis opiates have sort of moved more in the realm of cancer pain rather than the so-called benign pain syndromes. We tend to avoid that now for a variety of reasons, specifically the potentiation of pain centrally by chronic opiate use. But even still, it is a woefully underused therapy in cancer pain, despite it being proven to actually increase longevity. So that's an important point to make. Cordotomy as well, a really excellent treatment. I got training by Campalot. Probably the papers that you basically presented, I recognize them. They're from Campalot in Turkey. This is a fantastic operation, really low impact. The challenge is that very often we get consulted when patients are already moribund, usually with low platelets and essentially on death's door. And this is an opportunity to intervene on their pain when they have significant life expectancy left, usually 1 to 2 years, that can really make a huge difference in their lives. But overall, Alejandro, this was a very, very comprehensive, nice presentation of the options that we have to treat pain.
That was great. Alejandro, could you give me a real world example of the gate control theory in action?
You mean outside of the nervous system, a
No,
real, like an
no,
analogy?
I mean an actual example of how gate control works in your life.
Don't overthink it, Alejandro. Think.
One of the what do you do when you slam your thumb in a drawer or you burn it?
You immediately, put it
Shake
in
it.
some cold water, or you stimulate it in a different way.
You shake it.
You rub it.
Natural. You shake it, you rub it, and it works. And it's those sort of observations that led to some of the basic science. When I was a resident, I came very close to going down the wrong path and spent a year in the pain laboratory of Howard Fields and Mary Heinricher, and we were studying the mechanisms of potentiation of pain caused by opiates, which Dr. Coppell just mentioned. And at that time, they were interested in the central gate control theory, looking at on and off cells. But it's an absolutely fascinating area of neurosurgery and science. I'm convinced that we could learn more about it.
Mm.
Is there any DBS being done now anymore,
I
Brian?
mean, I have done, not since I've gotten to Sinai, but it was, because we had a different referral pattern. But I've done both thalamic and motor cortex stimulation for pain. Motor cortex stimulation was started in the early 90s by the Japanese groups, where through certain types of other surgeries, they saw the insight that stimulating the motor cortex could reduce pain. And so that usually involved a craniotomy and epidurally placing electrodes over the cortical surface and attaching that to a pacemaker type unit. Another is using, deep brain stimulation in two targets, the ventralis caudalis, which is the sensory relay in the thalamus, as well as the periventricular gray, which is a sympathetically and endogenously opioid related area of the brain. And both of those areas have been used. I've done those cases. Ironically enough, the very first use of DBS in the United States, in the world, essentially the modern technology, was for pain. Out of San Francisco, Josh, remember
Yoshio Hosoguchi and
Yep, that's right.
Hosobuchi.
And Don Richardson in Tulane. These are, I think still opportunities for our field. It definitely requires a village, in the theme of what started today's conversation, especially with chronic pain. Chronic pain definitely involves limbic and social and behavioral aspects of pain that need to be dealt with along with the therapy. And you need like a multidisciplinary approach to do this best.
Yeah, we were stimulating the periaqueductal gray, and yeah, it was pretty dangerous operation.
Did you cause panic? Because the original target was in fact periaqueductal gray, and then they moved to periventricular gray because of the panic that you
panic, but also eye findings and all kinds of bad things.
Yep.
Well, thank you. Stimulating topic.
I decided to bring up this topic out of interest, and I mean the comments and experience that you guys all had is so intriguing.
Thank you.
I think Chris had to go for an emergency surgery. Not unusual. So I think that probably ends our grand rounds. And then as far as the residents, we have a separate meeting. You guys should all have a separate link. I'll give you a minute and then I'll meet you guys there. Okay.
Great. Thanks, everyone.